So we have different methods of monitoring the baby. So a lot of it, first of all, comes from you yourself. So we'll be asking you how you're feeling, if baby is moving, and also just taking into account your history. So if you were preterm or if you're high risk, babies will be monitored differently than somebody who is low risk and term. So generally, with your consent, we would do an admission trace on baby, which would be for about 20 minutes, where we put 2 probes on your stomach and monitor the heart rate and your contractions for 20 minutes. And if that's okay, then you just progress on in labour. We listen in then to the baby's heart rate every 15 minutes for 1 minute with either a Doppler or a Pinard. If you're getting epidural, we need to do continuous monitoring, so that's a CTG continuously until you have the baby. There are other high-risk incidences where we would do continuous monitoring. So if there was meconium, if your waters went and there was meconium, generally for twin pregnancies in labour, again, they're not exhaustive lists for preterm delivery or for previous section, and there are lots of reasons why we would want to do continuous monitoring. And again, that's with your consent, and we discuss it with you. And even with the continuous monitoring, you're attached to the monitor, but you can still move around and adopt loads of different positions and all that. So it doesn't mean you're restricted to the bed. You can still use your birthing ball, you can still stand, you can still use the birthing mat. So yes, this is a teaching hospital, and we're linked with Trinity College and also the RCSI. So we have our own midwifery students. We also have medical students from the RCSI. We also have some ambulance students from Dublin Fire Brigade. We would have public health students and also general nurses from Trinity, who are linked to Trinity as well. We would also have some paediatric nurses coming through the system. So it probably is most likely that you would have 2 people if you're lucky enough looking after you in labour. So an epidural is administered by an anaesthetist and with your consent. So generally you're given an information leaflet first that you get to read through. Then the anaesthetist comes up and they'll usually talk you through the epidural and answer any questions that you have. First of all, you need an IV cannula into your hand or arm, and this is to give IV fluids. Often the blood pressure can drop when you get an epidural, so this just prevents that from happening. The epidural then goes into a space in the spine, so the anaesthetist is working behind you, and they usually do the procedure, and in about 20 minutes you are generally pain-free, and then that continues until you have your baby. If you have some breakthrough pain, we can give a top-up of the epidural, but you generally don't need to go through the whole procedure again. It's just given in through the catheter that's already in through your back. With that, just normally comes your legs are a bit numb, so you do have restricted movement, and generally people just kind of would move in the bed from kind of left to right or lying on their back. They can often sleep when they have the epidural. And yeah, it's definitely probably the only thing that makes it totally pain-free, your labour. And we have anaesthetics 24 hours, 7 days a week on the labour ward or in the hospital. So the cord is cut after delivery. So we do practice delayed cord clamping and cutting. Unless we need to give some emergency treatment to baby, which in that case we cut the cord straight away and bring the baby over to the Ohio to the resuscitator for the paediatric team to review. But generally we can practice delayed cord clamping and cutting. Anyone can cut the cord. We would usually offer the partner to cut the cord if he wishes, or if mum wants to cut the cord, that's fine. With regard to saving the blood, or I assume it's for stem cell, that can be done. We don't offer it as a service here ourselves, but it's organised privately, so you would need to look that up and organise it privately beforehand. So we don't offer them as in we don't organize it, and if you wanted to do that as an option, you would organize that yourself. Yeah, so we would always have skin to skin contact straight away. The baby's delivered up onto mum's chest and dried, and just put a warm towel on the baby. Again, unless there's some emergency situation where we need to cut and clamp the cord and bring the baby over to the resuscitator to the peds. So that would be just the normal process to put baby on skin to skin. So baby has a full head to toe check after delivery. So again, this is just in the normal circumstance. So baby's checked from head to toe either by a midwife or by a pediatrician. We check the baby's temperature. We also give vitamin K, which is quinaquine, to baby. It's usually by an intramuscular injection. Again, that is with your consent. If you wish to decline, you can, and you also have the option of giving it orally. As a hospital, we do recommend giving it 1 dose IM. So head to toe check, vitamin K given, temperature, and that's usually it. And then we encourage breastfeeding then after that.